So good morning, everyone, and welcome to the next in the series of the Viruses and Vaccines seminar. My name is Helen Chu. I'm at the University of Washington. So today we have two speakers. The first is Pavitra Roychoudhury, who is from the UW Department of Virology, and will be providing us a SARS-CoV-2 genomics update. And that will be followed by Cécile Viboud, who is here from the Fogarty Center and is a collaborator of ours as part of the Seattle Flu Alliance. And Cécile is a senior scientist in the Division of International Epidemiology and Population Studies at the Fogarty International Center at NIH. And her research focuses on the epidemiology and transmission dynamics of respiratory viruses, particularly for influenza and for SARS-CoV-2. And the work that she does is really at the intersection of genomics, computational modeling, and public health. And we're really delighted to have her here today to talk to us about modeling the direct and indirect consequences of the COVID-19 pandemic in the US and South Africa. So thanks to you both for joining us. And just before we get started, I just wanted to mention that the next speaker will be Jesse Bloom on December 20th. So mark your calendars. And then while the speakers are speaking, you can go ahead and put questions in the chat, and then we'll ask them at the end. So thank you. So Pavitra, do you want to, let me see if I can, there we go.
Hey, oops. Hi, everybody. Can everyone see me, hear me okay? Good. So thanks, Helen, for that introduction. I am here today to fill in for Trevor and fill his rather large genomic update shoes to give the 5-minute SARS-CoV-2 genomics update. So we'll see. All right, so here in the US, we're bracing for the winter surge. We are expecting to see cases rise as we enter the next couple of months. Currently, case counts and deaths are both quite low, but there is this tiny little rise in the percent positivity rate that you can see if you look at the CDC data tracker for US numbers. But then again, test volumes have also been really low. If you look at the volumes per week, that's the blue bars on this chart, they are lower than many times in the pandemic, and they're definitely at their lowest point in this year, and way lower than they were this time last year. So we have to take some of these stats with a grain of salt. And this is because of, closure of test sites, people not seeking testing, PCR testing, either turning to antigen tests and not reporting the results, or many other factors here. And another thing to keep in mind is that fewer samples being available for testing also means that for a lot of the labs who are doing sequencing, this is fewer samples for sequencing to determine what variants are circulating. So with that, it might be, with the low test volumes, it might be more useful to look at wastewater. Wastewater has been, if you look back over the pandemic, wastewater has been a pretty good leading indicator of surges. So the dark blue line is wastewater concentrations of SARS-CoV-2. This is from data from BioBot Analytics. And generally, increase in wastewater concentration has preceded a rise in case numbers. A few weeks later. That's the light blue bars and light blue line here. So currently, wastewater signals are also remaining quite low, but again, there's this tiny little rise. It's, I think, a bit early to say if this is a blip or it's going to keep rising, or how fast that rise is going to be. So if there is a surge, winter surge, then what variants might drive the surge? Here's data from the CDC's variant tracker. This shows the variant distributions among sequence samples, with the distributions in the last 3 weeks being projections from their nowcast algorithm to account for the lag in sequencing data. So what you see here among the distributions of variants in recent weeks is a lot of the lineages that Trevor mentioned during his last update. So BA 2.75.2, which he mentioned last time, has remained pretty low and hasn't really accelerated like we'd expected, but other BA5 sublineages like specifically BQ1, BQ1.1, and BF7 together account for about half of sequenced cases over here. So what we're seeing is this like mishmash of these different lineages, co-circulating lineages. So unlike the past waves where, you know, we saw BA2 replacing BA1 and then kind of BA5 taking off, this is kind of an interesting situation because we're seeing all of this dizzying array of sublineages that are co-circulating, or what the media has labeled as Scrabble variants, because, you know, they have letters like Q and X, or high scoring letters in Scrabble. But silly nomenclature aside, I think that, like, I really like to look at this particular graphic that's been maintained by Daniel Focosi and shared on Twitter, that kind of summarizes the mutations that many of these lineages share in common. And what's really interesting is that you see some combinations of mutations appear in multiple lineages on multiple backgrounds, suggesting that there might be some level of convergent evolution occurring. And of particular interest are some of these colored groups of lineages that bear particular combinations of mutations because of their escape from antibody neutralization and resistance to treatments like Evusheld and bebtelovimab. So this slide just summarizes what I just said. There are several lineages of interest, BA5 lineages of interest. So taken together, BA5 is still the majority overall lineage causing cases in the US. And these are some of the very sublineages that are rising in frequency. This is taken from Cove Spectrum. And if you look at these mutations, there are particular sites like 346 and 460 that have been previously predicted from like Jesse's group's experiments and other demonstrations to you know, be associated with escape. So these mutations have occurred on all of these lineages, and they seem to be rising in frequency too. And that is my update. And with that, I will switch, stop sharing, and Cécile can take over.
Thanks, Pavitra. That was actually great to see all of that together. I like the Scrabble analogy.
Okay, here we go. Well, thanks, Hélène, for inviting me to this seminar. And today I wanted to give you a little bit of data on our work trying to estimate the direct and indirect consequences of the COVID-19 pandemic, obviously a very large and long-lasting event. And so to do this, we're going to look at data on healthcare hospitalization and excess mortality from a variety of conditions to see if COVID-19 had an impact on those conditions. And then in the second part, we're going to look at modeling the circulation of endemic pathogens, which has changed a lot during COVID-19. And we're going to draw from examples in the US and South Africa. And at the end of the talk, I will talk more about some of the work we're now doing in the Seattle area with Seattle Flu Alliance colleagues, including Hélène and Trevor. So starting with the impact of the pandemic on mortality and healthcare use, one of the things we've been looking at is excess mortality, and this is a method that has been used maybe for centuries to quantify the impact of large-scale events, whether they're pandemics or heat waves. And the idea there is that excess mortality is mortality above a baseline, which is based on what you have seen in prior years. So in our case, prior COVID-19. And then what we're trying to separate are the direct consequences of the pandemic on these excess mortality estimates, which are the results of SARS-CoV-2 infection, versus the indirect consequences of the pandemic, which are perhaps behavioral or health effects. And I will get a little bit more into the details of the mechanisms we're thinking might play a role there. And then for some conditions, there might just be no consequence of the pandemic, and mortality might proceed in the same way that it has in past years. So again, thinking a little bit of the mechanisms, if we think of the direct consequences of the pandemic, where a SARS-CoV-2 infection has triggered death, there are two possibilities. One, this death has been recorded as underlying COVID-19 death and tallied in official statistics. So that's the easy part. But we also think that there are a number of deaths that are not recorded as underlying COVID-19 because they have been missed, perhaps because there was no testing, and that's probably more relevant early in the pandemic, but also perhaps a trigger in someone who has had underlying conditions, for instance, diabetes, and some of those conditions might be the leading cause of death on the death certificate. And just to illustrate this point here, we're looking at weekly mortality from US data. In black, we have diabetes, again, a well-known risk factor for COVID-19, and that was identified quite early on. And then in red, you see respiratory and COVID-19 weekly mortality, which is our most specific indicator of the COVID-19 impact. Just to get you situated on this graph, because we're going to look at a lot of those. On the right-hand side, obviously 2020 through 2022, that's the pandemic period. And we see at the scale of the US, 4 main waves of activity, 3 waves of Wuhan, and then the wave of Delta in the summer of 2021. These data end at the end of 2021, so just before Omicron arose. And this is in part because we want to be able to interpret the serology data well. But so to go back to this idea of a direct consequence of the pandemic, is if you look at the diabetes time series in black, you can see that you have spikes in mortality that align very well with deaths from COVID-19. And so there's this idea that perhaps we do see deaths that are due to SARS-CoV-2 infection among the diabetes-coded mortality. And this is something that we have done also in past flu pandemics as well as seasonal flu. And so if that happens through this mechanism, we should see synchronicity between cause-specific mortality, for instance, diabetes mortality and COVID-19 deaths. The second idea is the indirect consequences of the pandemic, and there they are varied. One of the phenomenon could be through saturation or aversion of the healthcare system. And we can think of this very early on in the pandemic, spring 2020 in New York City, for instance, where the system was overloaded and people turned away from it. And perhaps there are people who are not seen for their chronic conditions and might then proceed to die, maybe not immediately, but at some point later in the pandemic. So this saturation or aversion would tend to increase mortality. On the other hand, we can also see depressed circulation of endemic pathogens, and we've seen a lot of this during COVID-19. And that, so less flu, less RSV, etc. And because of that, we would see less mortality. And then there are other societal consequences of the pandemic, which are starting to be observed, in particular on suicide and opioids. And those could be related to the strength of intervention or how long it has been since the start of the pandemic, or also caseload, if you're thinking of suicide or losing someone in your family due to COVID-19. So a range of mechanisms. And just to illustrate this point, we're looking here at external causes of death in black, which include suicides, opioids, accidents, and injuries. And then the same time series of respiratory and COVID-19 that we were looking at before. And there you can see in the 2020 through 2021 period, you see this large increase in external cause mortality. However, the timing of it is really different from what we see in COVID-19. We actually see large peaks, sort of prolonged peaks that are almost out of phase with COVID-19. So we would assume that for some of those mechanisms, there would be less or no synchronicity with COVID-19, perhaps more with intervention or hospital load. And then the third option or idea is that maybe for some condition, there's just no consequence of the pandemic. And here we're looking at cancer, which illustrates one of these patterns where you see that cancer tends to be quite flat as a whole when you include all cancers together, and has proceeded as pre-COVID-19 during the pandemic period. So we're going to use the statistical approach to try to quantify a little bit more what is the direct contribution and the indirect contribution of COVID to a range of conditions. So we're using national death certificates from the US. We can break them by state, by week, age group, and underlying cause of death. So we're looking at those 8 conditions here. And we're looking at these 8 conditions, both because they've been associated with respiratory virus infections in the past, but also because the National Center for Health Statistics has been collating almost real-time data for those, so we can have a nice view of how the pandemic is proceeding. And then we're doing a 2-stage estimation approach, where in stage 1, we're estimating weekly cause-specific excess mortality for each of those 8 causes. And the process of doing this is we fit a seasonal baseline. It's a regression model with seasonal terms and time trends to the pre-pandemic period. And then we project that baseline forward. And then excess is the difference between observed mortality during COVID and baseline mortality. And then the stage 2 part is the attribution model, where we try to explain this weekly excess mortality we have found in stage 1 as a function of the intensity of COVID in different weeks of the pandemic, the intensity of interventions. We're using an index that's created by the Oxford group, and it's been used in a lot of studies that sort of combine the number of interventions in a different locality, and data from HHS and hospital utilization. So here are examples of mortality time series for different jurisdictions in the US on the left. So you see US as a whole and then 5 different states. This won't come as a surprise that there's a lot of heterogeneity, both in COVID-19 impact, but also in mortality. For instance, take California, which has a major impact in the winter 2021 versus New York at the bottom left, where most of the impact is in the spring of 2020. Now, almost every state has a sort of a different story depending on when the different variants were seeded and also the amount of interventions and vaccine coverage later on. And so sort of as a sanity check of our excess mortality estimates, we validate them against data on seroprevalence in the different states in the US, which is the graph that you see on the right. So on the x-axis, we have laboratory seroprevalence, so the number of people who have been infected at the end of 2021, versus on the y-axis, we have excess mortality from respiratory conditions and COVID-19, again, our most specific indicator of COVID. And you can see that there's a nice correlation between the 2 types of data set that lend support to the excess mortality approach. I will say that we find also that the slope on this curve also gives you the infection fatality rate, which is 0.6% for this data. It sort of aligns with what we've seen in other studies. Interestingly, we don't see a tremendous decline in infection fatality rate through 2021, despite the rise of the vaccination program. And part of this is due to the fact that the Delta wave was actually a more severe variant per infection. So vaccination helps, but then Delta is harmful. So overall, we get to this 0.6% fatality rate. And of course, a much higher fatality rate in older age groups. So now we can look at how different conditions behave throughout the pandemic. So you see those 8 conditions that I've listed before. And just to highlight a few patterns, most of the chronic conditions we're looking at, from Alzheimer to diabetes to heart disease and cerebrovascular disease, tend to have the signature 4 waves of the pandemic that we see in the COVID time series, suggesting that there is an indirect effect there. I will also note that the sort of indirect impact seems to lessen a little bit during the 2021 time period, perhaps as the vaccine is rolled out, there's sort of a decoupling between chronic infections and COVID-19 activity. And then cancer, as we've seen before, there is not much of a change during the pandemic. And I should say here that the black are the observations and then the green is our seasonal model, sort of reflecting what we would expect if COVID-19 wasn't there, along with an orange shaded area that represent the 95% confidence interval. And then to me, coming from respiratory research, what was the most surprising for this pandemic is the impact on external causes of death. Again, accident, homicide, suicides, where you see this substantial increase of a baseline, which doesn't align with COVID-19 activity. So now we can look at the result of our attribution model, where we've sort of regressed the excess mortality measures against interventions and COVID-19 activity, as well as healthcare hospitalization. And what you see in this table, particularly on the right-hand side column, is how much the model attributes to the direct impact of SARS-CoV-2 infection, so the direct impact of the pandemic. So of the 1+ million deaths that we have during this time period, based on excess mortality from all cause, 84% are attributed to the direct impact of SARS-CoV-2 infection by the model. So the large majority of mortality we've seen during COVID-19 is direct SARS-CoV-2. And then from Alzheimer, diabetes, and heart disease, we see substantial also direct contribution of SARS-CoV-2 infection on these deaths that are not listed as underlying SARS-CoV-2 death on the death certificate. Should note also that the confidence intervals are a bit larger on those chronic conditions. And then we also see potentially an impact on cerebrovascular disease, although it's not significant by this model. And then interestingly, for external causes of death, SARS-CoV-2 infection has a negative attributable fraction, which means that excess mortality from external causes tend to be high when COVID incidence is low. But on the other side, through this regression model, we see an important impact of the strength of interventions. So the time periods where we see high mortality from external causes coincide with periods where we have high interventions. And then there's no impact on cancer for any of the predictors that we've looked at. And on the left-hand side, you see how well the models represent the data. So the model is in red and the observations are in black. In general, the all-cause model is really, really good. The chronic infection models are relatively, they have moderate to good fit. External cause is good as well, but the cancer model is not really good. Again, we can't really find any predictors of change in the first place because there are very little changes in cancer throughout the pandemic. So the other thing we can look at is, again, these external causes of death, because they're not all created equal. You can split them by subcategories. So we're looking at 5 of them here and try to see what is the pattern for those. So perhaps starting with the good news at the bottom, with suicide, we do not see a rise in suicide mortality. Maybe mortality is a bit elevated during 2021, but it's within the confidence intervals of past years. So we can't see any impact of COVID on suicide. But we do see large increases in accident and injuries, around 12 to 13%, drug overdoses, and then assaults and homicides, both in summer of 2020 and summer of 2021. So substantial increases. The other interesting thing is to look at how different age groups responded to the pandemic. Obviously, we know that COVID, SARS-CoV-2 infection has a major mortality impact in older people, and we see that in this data. So we have 6 different age groups here, from youngest top left to oldest bottom right. And we can see here, if we start with the under 25 at the top left, that we see those like sort of 2 rises in mortality during the summer of 2020 and 2021, which are not really reminiscent of the patterns of COVID-19, but more reminiscent of what we saw in external causes. And in fact, the model only attribute 11% of these excess deaths seen here in under 25 to the direct impact of SARS-CoV-2 infection. And most of the model wants to attribute those deaths to the amount of interventions that we have. In the 24 to 44 years old, there's also still a major impact of intervention and less of an impact of COVID-19. And then in the 45 and over, this switched to being mostly COVID-19. And interestingly, if you look at the oldest age group, 75 and over and 85, we see that more than 100% of excess deaths are attributed to COVID-19, which could be due to 2 phenomena. One of them is that our baseline is too high, so the number of excess deaths that we have is underestimated. And the reason why this baseline could be too high are twofold. One is that we could not really include the fact that a lot of endemic pathogens were depressed, and so that will lower mortality. Because we're not really monitoring a lot of these pathogens throughout time, we can't really include them explicitly in the model. So maybe our baseline is too high, and hence our excess mortality against is underestimated. And the other idea is that maybe there's a little bit of harvesting going on, which you can see at the end of the winter 2020-21 wave, which is the biggest wave in these older folks. And you can see that the observations in black start to fall below the baseline in green. And so harvesting is this idea that if you have a large mortality event, you're just going to kill your very frail population, and what's left right after that is a population that's a little bit healthier, and hence their baseline mortality is higher. So this has been shown for heat waves, very difficult to show for infectious disease, but perhaps we haven't seen something as clear as COVID-19, as large scale as COVID-19 before. I should also say that when we compare these excess mortality estimates with official statistics in these age groups, 75 and older, we also see that we're underestimating excess. So again, this is consistent. We also looked at how COVID-19 compared with seasonal flu, and so it's a bit difficult because COVID-19 has been a long-lasting pandemic for many, many months. Flu doesn't last for many months. So we compared a wave of COVID-19, and we took the November through March 2020 to 2021 wave, which is sort of the most severe wave at the scale of the US, versus a recent severe flu season, 2017 to 2018. And here you can see on this graph how death rate from flu on the x-axis compared with death rate from COVID during that winter period across all states in the US. And overall, there's about a 4-fold higher impact of COVID relative to flu, with some variations between states, but all states had a bigger impact of COVID compared to flu. So in summary, on the study of direct and indirect effect, we see that the majority of deaths from March 2020 to December 2021 are direct consequences of SARS-CoV-2 infections. We see these direct consequences in deaths from chronic conditions that are not listed as underlying COVID deaths, particularly diabetes, Alzheimer's, heart disease, and cerebrovascular disease. The attributable fraction ranges from 30 to 80%. That persists throughout the pandemic, including after vaccination, although we see the effect starting to decouple in 2021 with chronic conditions. We don't think it's captured in official statistics. And we have seen similar patterns and effect on viral infection on chronic disease, interestingly, during the 1968 pandemic. We do not see any change in cancer mortality. And also, even though most of the impact of the pandemic is through direct SARS-CoV-2 infection, we do see substantial indirect effects among the younger population and external causes of mortality. And here we're not saying that intervention caused this death, but we just want to call attention to the fact that if we have these long-lasting behavioral and social distancing changes, we would expect some of those impacts to happen, and we need to have systems in place to try to mitigate them for next time. We do also adjust for healthcare utilization, although we do not see a clear impact of that covariate in our model. However, I will say that some of the HHS data is a little bit shaky at the beginning of the pandemic, so maybe there's some of that going on. So we've also looked at similar phenomenon in South Africa. So in South Africa, unfortunately, we can't look at mortality yet because the only thing they have so far is all-cause mortality. Their cause of death estimates will take a few more years to tabulate, but we can look at the hospitalization data, and it's through one of their private healthcare system that has recently become analyzable, and interestingly has a few historical years, allowing us to fit baseline in the same way that we've done for the US. So what you're looking at here at the top are admissions for respiratory disease in South Africa before the pandemic, and then after the pandemic, which is on the right-hand side of this graph for 4 different age groups. The black lines are the observations, and then the blue line is a baseline, seasonal baseline fitted to historical data. And then the differences between baseline and observation are colored in green if you have fewer admissions than expected, which you see in the 0 to 5 and 5 to 19 years of age throughout the pandemic. And then in orange yellow, when you have a positive excess, so more admissions than expected, which you see in the 49 years old and in the 50 and over years old. And at the bottom, you see a graph of weekly differences from baseline for the pandemic for those different age groups. And I will note here that even though overall you see less burden in the children than expected in pre-COVID years, you do see a little spike in the spring of 2021, which is, we think, actually the impact of the RSV epidemic there. And then I should also say that here we're catching 3 waves of COVID-19 activity in South Africa, 2 waves, a wave caused by the Wuhan strain, then the Beta variant, and then the Delta on the 3rd wave. So we can look at changes from the baseline, not only in respiratory admissions, but in admissions for a range of conditions throughout the pandemic, those 3 waves of COVID-19 activity. And we see that overall admissions have tended to decline, sometimes by quite high level. If you take asthma, for instance, it's around 70% decline, but also in intestinal infectious disease, non-COVID-19 pneumonia and influenza, TB, diabetes, myocardial infarction, etc., as well as trauma. And so the question is, we see a decline in these admissions, and for some conditions like perhaps asthma and intestinal infectious disease, we think perhaps this was because of depressed circulation of pathogens. But for things like diabetes or myocardial infarction, we can't really see a direct impact of COVID-19. And so we think these are just people who are avoiding the healthcare system and might get in trouble later on. And so we might see this decreased hospitalization translating into increased mortality later on. So this is something we want to follow up once the mortality data will become available in South Africa. And I should say that this is work that is done by Amanda Perovsky, who is co-affiliated with the Brockman-Batty Institute and our group at NIH. So we can also see how interventions relate to this change in admissions. So there's a lot of data on interventions and behavior and mobility throughout the pandemic. We're just showing a few of them here. So on the left-hand side, we see the Oxford Index of Interventions that we've discussed earlier. That's the curve in gray, and then the COVID-19 activities in blue. And then the different lines represent different stages of interventions in South Africa. They had very reactive interventions depending on how well they were thinking they were controlling COVID-19. And then on the right-hand side, we see mobility data. But clearly there's a large change in behavior during the lockdown phase, which is in the early months of 2020. And then there's a little bit more also changes in mobility during the Beta variant wave, and then again during Delta. And so we can see how a weekly change in mobility and behavior relates to weekly changes in admissions across all of these conditions that we've looked at before. And we see that most of these conditions are actually related to changes in mobility. So here we're looking at one of the Google mobility indicators. And you can see pretty strong relationships for most of these conditions. Interestingly, if you try to do the same thing with COVID-19 cases and mobility, we don't see such a clear relationship there. But so we think then that the behavior changes and social distancing is really what drove those decreased admission in South Africa. So I will move on to try to understand a little bit more the impact of the pandemic on the circulation and transmission of respiratory pathogen. Clearly now flu and RSV are almost daily in the news. We are under pressure in a lot of hospitals across the country with this sort of double epidemics of non-COVID pathogen. And part of it is because throughout COVID-19, there's been really pumped up circulation of those pathogens. I'm just highlighting here a few of the studies throughout the world that have concentrated on RSV. And so we've been working very closely with our collaborators in South Africa because they have interesting RSV surveillance data, and they were worried about what RSV might do in 2022. So here we're looking at some of their surveillance data on the left, where the past years are in gray, with blue illustrating the average sort of circulation of RSV there. So RSV in South Africa is a fall epidemic. which peaks around week 15 of the year, with week 0 being the first week of the year, January 1st. And then in red, you see what happened in 2020. So the RSV season started a bit late, and then there was interventions came in place, and so transmission decreased. And then there's another peak later that year that is completely out of season. And then in 2021, we also have a season that starts as usual, but then because of the Delta variant epidemic, interventions are put back in place, and so transmission decreases. So the idea was to try to quantify some of those changes and fit a mechanistic transmission model to those data. The other thing of interest is to try to understand the age dynamics of RSV and how that might change as you see a gap in infections due to COVID-19. And here we're looking at the breakdown of hospitalizations for RSV in pre-COVID years in blue and versus 2020 in red and 2021 in green. And what we can see there is that there's a bit of an age shift towards older age groups, especially 6 to 11 years old, who tend to have more of a burden than earlier years. And that suggests to us that severity is driven not only by prior immunity, but also by age. And so the 6 to 11 month old in 2021, for instance, are getting in the hospital because they are getting their primary RSV infection. And even though they're a bit older, that still drives them to the hospital. So infection, so severity is the combination of both, whether you've seen RSV before, but also age. So we fitted a transmission model to this data. And this is a relatively classic SEIR framework where people move from susceptible, exposed, infectious, and recovered. And the equation that you see here is the equation for transmission, which in short is a term for seasonality, because we've seen that RSV is very, very seasonal pre-COVID. That's the term with the cosine. And then the term on the right-hand side is a term of mixing between different age groups, because we have an age-specific model, which is very important for RSV since infections are so concentrated early in life. We also have maternal immunity in this model. And this is a model that we've sort of repackaged from previous work that was done in Western Australia, and that we just now can fit to the South African context. So here are some predictions on the model. So we did 2 rounds of predictions. One round was at the end of 2021. So we had no data in 2022, and we were trying to predict what RSV would look like in the following year. So that's what you see on the left-hand side here, with the black line representing the observations through to the end of 2021. And then the colored bars representing the projections from the model that are color-coded by age group. And you can see that the model predicts a very large peak in 2022 with also an earlier epidemic than usual. And then you can also see 2 periods that are shaded in gray here in this model, which are the period where we had 2 strong lockdown periods in South Africa. And we estimated from this model that there was a reduction in 47 and then 37% in the second period in RSV transmission because of those interventions. Then, so those projections were made available to the public health system in South Africa, and they were also disseminated to hospitals to warn them ahead of what we thought was going to be a pretty large and nasty RSV season. Then on the right-hand side, you see what actually happened during these first 6 months of 2022 in South Africa. And you can see in black here that the peak is actually not that high compared to past years. However, it is an earlier season than usual. And so we went back to the drawing board and we wondered what happened, why didn't the model catch that? And actually what happened was that there was an Omicron wave just coinciding or just before the RSV epidemic, and then there was quite a bit of social distancing still happening, or just people being simply sick and staying at home and not having contacts. And when we allow for this additional period of intervention, so it's the third bar in gray that you see on the right, we do see that the model then starts to reproduce the data a lot better. So we have still an early RSV season, but the peak is modulated by this social Omicron distancing. And there we assume that it's only a 15% decrease in RSV transmission, so not as much as the true lockdown periods. We can also see how the model reproduces the age structure of hospitalization. So here we have the observations in the data in 2022 in dark blue, where we do see an increased impact in the older age group, 3 to 5 and 6 to 23. This age shift is also projected by the model, although it is somewhat underestimated. So there's still something that's not entirely well captured about the age structure. So in summary on this RSV work, we see in South Africa, following the disruption from COVID-19, severe infection shift to older age groups, so infants older than 6 months, again suggesting that severity is not only a reflection of age group, but also prior immunity. We made those projections available in March 2022, and that was used by our colleagues at the National Institute for Communicable Disease to help with hospital management. Unfortunately, they don't have access to a lot of prophylaxis in South Africa. It's really reserved to the most affluent population. However, they were able to shift wards to be able to anticipate a larger RSV season. And in fact, the surge was not as high as predicted, but it was an earlier than predicted epidemic. And we think this is likely due to the residual effects of Omicron. And I'm going to spend a few minutes with what's available, what's left of this talk on talking a little bit more about studies that we're now doing in the Seattle area as part of the Seattle Flu Alliance collaboration. So I think perhaps a lot of you know about the Seattle Flu Alliance and Seattle Flu Study, but just to jog your memory, the study was established in November 2018. It was led by Helen Chu and Trevor Bedford and others, and funded by Gates Venture. And the idea was to do hospital and community surveillance of respiratory illnesses. And on the right, you see a nice paper by Helen from a few years ago, listing all of the pathogens that are tested throughout this study. And when we came on board, we were really interested in using this very detailed surveillance data to try to reconstruct incidence of different pathogens and try to model this against data on behavior and mobility, particularly during the COVID-19 period. To try to reconstruct incidence, there are a lot of data streams coming into this study. So it's a little bit complicated, but the general idea is that we use indicators of the people with respiratory symptoms, and we multiply this by indicators of people that are positive for respiratory pathogen as tested through the Seattle Flu Study. And we also have a combination of hospital and community surveillance. The graph in color at the top just represents sort of a shift in the coding of hospitalization. This is from Seattle Children's Hospitals before and after COVID. In fact, there was a lot of pre-op testing that was put in place during the COVID-19 pandemic. So we have to sort of adjust for that in our data. But just to make a long story short, we do use all of the data that are available through the Seattle Flu Study to reconstruct daily incidences for 26 pathogens. And you can see time series for 3 of those pathogens here on the right from our community and hospital surveillance. And then in blue, you see the combined daily incidence data, which we then use in our modeling approaches. And so we can then use additional data on movements in the Seattle area to see how these movements correlate with incidence. And this is the work done by Amanda Perowski, again, with both at BBI and at the NIH. So one of the data set, very detailed data set that is available throughout the US is the SafeGraph data, which tracks the location of mobile phone users based on their GPS. On the left-hand side here, we're looking at maps of influx of visitors into King County at 2 different time periods. March 2, 2020, so right when the stay-at-home orders were put in place, and then July 2020 when interventions started to be relaxed. And then we can track sort of those movements throughout time, which you can see on the right-hand side here for different types of movements within cities, a number of incoming visitors at the top, foot traffic to schools and bars and fitness centers. And then a third indicator at the bottom, which has been used a lot in infectious disease studies, which is the percentage of devices staying at home, which has been shown to be well correlated with transmission of pathogens. And you can see in particular that the period of the so-called lockdown in orange is marked by large changes in some of those mobility indicators. And then things start to rebound later on and then go up and down depending on different waves of COVID-19. So on the virus side, we can look at not only incidence, but a measure of the reproduction number, which is our measure of daily transmission rates. So you can see here graph for 8 of the pathogens that we're tracking with the epidemic curves in the background, and then the sort of slightly declining trends are the estimates of RT, number of secondary case per primary case at each time point of the pandemic. And we're fortunate to have 2 years before COVID and then the COVID-19 period in this data. So once we have those daily estimates of the transmission rate, we can then correlate them with mobility. And this is a bit of a busy graph, but I'm just going to give you the highlight. What we're looking for here, if mobility is predictive of transmission of pathogens, we should see that mobility changes earlier than transmission of pathogens. So that's what the x-axis is looking at. It's the lag between your transmission and mobility. And then on the y-axis, you have the correlation coefficient between the two. So a predictive indicator would be on the top left-hand side, which is marked in yellow because it would lag a lot, but it will also have a high positive correlation. And we see that mobility tends to be highly associated with the transmission of those pathogens during the lockdown period, which is sort of the middle of this graph here, March 2020, April 2022. But then some of those relationships disappear as intervention are relaxed. And when we look into 2021 and 2022, we see a decoupling of those relationships between transmission of endemic pathogens and mobility. The other thing that we see is that, interestingly, when you do this analysis with COVID-19 transmission rate, we see that transmission precedes mobility changes during the lockdown and not the other way around. So that suggests that people were sort of reactive to the number of COVID cases in their community rather than the other way around. So the other thing we can look at with this data, because for one of the surveillance stream, which is looking at community infections, we have a lot of individual level information. We can look at risk factors for infection. And we were particularly interested in comparing an endemic pathogen like rhinovirus with SARS-CoV-2. So the unique feature of rhinovirus is that it was depressed during the strict lockdown period, but it rebounded very quickly and has been circulating really throughout COVID-19. And so we can look at the risk of infections for those 2 pathogens and try to compare them. So the top graph represents risk factors based on demographic or behavioral parameters, and the bottom represents symptoms. And the first thing to note is that we can see a lot of risk factors for COVID, which are in purple throughout the 2020 to 2022 time period. But there are much fewer relationships that we see for rhino. One of the biggest relationships with rhino is age, not surprisingly, because we see so many infections in younger children. But we also have a reverse effect of school attendance between SARS and rhino. Interestingly, we see quite a few disparities by race and ethnicity, as well as region within the greater Seattle area, both for SARS-CoV-2, but also for rhinovirus. So we were wondering whether some of those disparities sort of disappear as a pathogen becomes endemic, but for rhino, we still see those. And then we see some effects of household size as well. And so for symptoms, we also see quite a few differences between the two pathogens. Maybe the most notable is that loss of smell and taste has been, noted many times as a hallmark of COVID-19, and we see it in those data, although it has been attenuating in recent waves. So these data also allow to sort of track risk of infection, risk factors for infection over time. And we'll also see some differences between variants of SARS-CoV-2, which I don't have time to get into. And this is work done by Chelsea Hansen, who is also at the Brodmann-Batty Institute and co-affiliated with the NIH. So I'm going to end here, but just to conclude, I think we've seen through sort of this work that the COVID-19 had a profound effect on both healthcare use and mortality from a range of chronic conditions, both through direct SARS-CoV-2 infection, but also through indirect effects, in particular on mental health. And we also seen that the pandemic had a major impact on multiple endemic pathogens that have been suppressed for over a year or really perturbed across the world. And the rebound patterns vary a lot, and we would really want to try to understand some of those better. And some of the differences come from perhaps differences in seeding patterns and persistence of those pathogens, persistence of immunity. And we're now conducting serology studies in the Seattle area to try to link how immunity changed over time with transmission of those pathogens. Different seasonal signature, if pathogens peak at different time and interventions come at different time, you can see how intervention might have different effects. If we're thinking more broadly, globally, there would also be potentially gap in vaccination for a lot of childhood infection that might also come into play and try to understand the rebound of this pathogen in the post-COVID-19 period. And I think also just looking at data from a lot of countries, we also see that almost every country or every location tells a different story. So it is important to try to find locally relevant data on both disease activity, but also interventions and behavior. And with this, I will end and thank all of my collaborators at the Fogarty International Center. The top is our disease modeling group, and then all of the Seattle Flu Alliance investigators who have been participating in this study, and especially on the last part. Particular thanks to Helen, Leah, Janet, Alpana, and Trevor. And with this, I'll be happy to take questions. I hope I didn't talk for too long.
That was wonderful, Cécile. Thank you so much. It was so great to see all of the data from Seattle. I actually haven't seen a lot of it before, so thank you. Lauren, there's a question from Lauren. The question is, can you use your model to identify certain diseases or treatments that correlate with a poor vaccine response? E.g., I would expect a correlation for people on immunosuppressants, but there are other groups we need to figure out how to protect differently or better.
Yeah, so I think for a lot of the analysis that I've shown, it's on a population level, right? So we don't necessarily have, data on the individual response to vaccination. I think you could still try to come up with hypotheses for this data. I mean, for instance, we are right now looking at different types of cancer because, some are more immunosuppressed than others. And we do see some differences in how they respond to COVID-19. And you could also look at, patterns before vaccination and after vaccination. And if you didn't see pattern, changes after vaccination, maybe you don't have, a good immune response. But again, those are sort of ecological studies, right? So the idea is that you sort of identify hypotheses, but then you need to test them with more detailed data at the individual level.
Cécile, can I ask you a question, which is, what are your thoughts about establishing a new baseline for calculation of excess mortality in the sort of the post-pandemic period, and how would you go about doing that?
Yeah, I think that's a great question. We've sort of been, projecting forward this old baseline, which is now 2+ years old, and a lot of things have changed. I mean, I think once we get to the other side of COVID-19, whatever that means and whenever that happens, we'll be able to fit again that baseline to new data. I think we're probably not quite there yet. Maybe another summer would be useful. I think also one one other approach that people have used is to include all of the data in the model, so including the COVID-19 period data, but have an explicit indicator for how much COVID you have directly in the model. However, when you have too few weeks with COVID-19, like if you have 10 years of pre-COVID and just 1 year of COVID, that's just not enough to estimate that COVID-19 factor. I think now we get it to a point where we might have enough data to fit these types of models, which would solve the problem because the baseline is estimated at the same time that the excess is estimated. When we did this work that I'm showing here until the end of 2021, it was still too short to look at this. But I think that's the way forward. I think also looking at explicitly including circulation of a number of respiratory viruses would be great. And this is work that Chelsea is conducting in our group. But when you have really good surveillance for many, many pathogens like you have in Seattle, you can include all of that in the model, right? And then you don't run the risk of maybe overestimating your baseline because you know that there's been depressed circulation of those other pathogens. We can't do this at the scale of the US because there's just not a lot of good surveillance for everything at the local scale.
Thanks so much. It looks like I just have one more question if there's no others, which is I'm wondering about your thoughts on this this indirect effect in the younger populations and the effect of the interventions, and what, taking that that data into consideration, what would you think would be sort of the best strategy moving forward? Because the interventions may or may not be causally associated with this excess mortality in the younger population, but clearly the effect of a lot of the interventions we put in place did have a pretty damaging effect on particularly teenagers and younger adults. And so what are some ways to mitigate this as we think about the next time?
Yeah, well, I mean, I think it starts with, because we always have those problems, I think, in this population. They have been really exacerbating during the pandemic. For instance, if you look at opioids, the states that had an opioid problem or a larger opioid problem to start with just get an even larger one during COVID-19, right? So I think just trying to understand and mitigate those effects, even in a non-COVID year, might help you during a pandemic period where you have a lot of these interventions. I'm a respiratory virus person, right? So I know nothing about how to prevent this type of issues. It's just that you see those really exacerbated in particular populations during COVID-19. But this is not in places that never had any issues. You do see those in places that always had these issues, right? And so starting by addressing those problems in regular times, will also help the next time we have that. Hopefully not in our lifetimes, Helen, but
you don't think? I think. Anyway, thank you so much, Cécile and Pavitra. That was wonderful. It was such a great session. I learned so much. And again, our next session is on December 20th with Jesse Bloom. Thank you to everyone for joining. And the recording will be online shortly as well. Thank you.
Thanks. Bye, everyone.